There's only 3 indications to put somebody on mechanical ventilation. Can't ventilate them, can't oxygenate them, or can't protect their airway. So all those things like neuromuscular disease is no ventilating. Drug overdoses can't protect the airway. All the other things fall into one of those 3 categories, right? So there's certain bells and whistles we set. Mode we're going to skip because that's what the second part and the most important part is about, okay? You can set a rate. Doesn't matter. If they're hypercapnic, high PCO2 does not hurt anybody. The worst thing you can do is start hyperventilating them, and the next thing you know, you got PEA, because that's one of the causes of PEA, right? Mm-hmm. And when I first came to town, I saw it. You know, in the ER, they just bag the shit out of people. You got to tell them to slow down. Give them 8 to 10 breaths a minute. So it doesn't matter what you put your rate on. You can always adjust it depending on your blood gas. What do you and I breathe at?
12.
Or less.
Yeah.
All these people, they record 20 breaths per minute in the hospital for hyperventilating, if that's true.
12, 14. Yeah, that's usually.
And I think one day they're going to all get in unison, all those 20 breaths, and the hospital's just going to implode. It's going to be too much negative pressure. It's just going to all cave in. Kind of like lightning in the blood, as Dr. Thompson says. Tidal volume. It depends on the disease process. And we used to put it at 10 to 15 milliliters per kilogram, and we probably hurt people.
Wow.
We don't breathe at that unless you're running. So now we try to set it somewhere between 5 and 8 to start. And again, when we talk about COPD, for most people, like post-op patients, these things don't matter. But for COPD patients or pulmonary fibrosis patients, they do. So 5 to 8 milliliters per kilogram. FiO2, doesn't matter. Give them 100% till you get your blood gas and they're stable. The only time you have to worry about it is if they're on amiodarone, okay? Because that'll generate free oxygen radicals and cause ARDS. So you want to minimize it with amiodarone, otherwise it doesn't matter. Now, you don't want to leave somebody on 100% oxygen because it's toxic to the lungs. But put them on 100%, oxygenate them till they're stable, then you can adjust it. Peak flow. You know what peak flow is? Peak flow is what they set the flow on the ventilator. So if you put someone on an IMV of 10 and a tidal volume of 700, the peak flow is what that tidal volume is delivered at in liters per minute, okay? If you don't designate a peak flow, respiratory sets the peak flow. Well, that's the other thing. I knew I was leaving off something. To where your inspiratory to expiratory ratio is 1 to 3, because that's what we breathe at. And again, for most people, that's fine. For chronic lungers, it's not fine, because they need more expiratory time because they have obstructive airway disease, so they can't get air out. So you want to set your peak flow to where they have the best, highest inspiratory to expiratory ratio they can, like 1 to 5, 1 to 7. So if you don't set it, respiratory will set the peak flow, so the IDE ratio is 1 to 3. So that's why sometimes you'll see us play at the bedside and say peak flow of 100. The trade-off for a higher peak flow is a higher peak inspiratory pressure and a higher risk of baritone. You know what sensitivity is? Sensitivity is what you set the ventilator on to where when the patient triggers the demand valve by decreasing the airway pressure by that much, then the demand valve on the ventilator opens to where, depending on the mode, the ventilator will take over the rate of breathing. So it's usually set at -1 or -2, or 1 or 2. Okay. So if you have it on a sensitivity of 2.0, when he starts to inspire and generates a negative pressure of 2 at the ventilator circuit, then the demand valve opens and the ventilator takes over the work of breathing. So if it's 1.0 or 1.2, that's not much work of breathing. I've seen them. You walk in, sometimes the patient's going, and the machine's not triggering. I've seen them on 10 and 20. So that's just something you got to make sure. The waveform is what that tidal volume will be delivered at. You have 3 choices on a ventilator. You have a square waveform, you have a taper waveform, and you have a sine waveform. Okay? If you don't specify, the taper waveform is what they'll set at. So most of it's delivered in the first 1 to 2 seconds, and then the flow tapers off. That's how you and I breathe. The sine waveform, there really is no need to ever use it. The square waveform becomes important when we're going to talk about severe obstructive airways disease, because it's one of the things you can set to increase the IDE ratio. because it's delivered faster at a constant rate. The trade-off for this, again, just like a higher peak flow, is a higher peak inspiratory pressure. Then you got various alarms, okay? So now, let's talk about modes of mechanical ventilation. Let's see.
Christian was sitting in the conference room.
Okay. So what these are supposed to be is a pressure time curve and a volume time curve. And what I want you to be able to, this is going to be very simple. I want you to take away from here, if I have my patient in a certain type of ventilator, or a certain mode of mechanical ventilation, what work is he doing and what work is the ventilator doing, okay? So first of all, let's talk about CMV, or assist control, which we don't use a whole lot around here. But if you go to another city, you're going to see a ton of it, because that's what most people use. And I'll tell you why we don't use a lot of it here. If you put someone on a, man, I really need another board. Let's say we have them on assist control of 10, tidal volume of 600, PEEP of 5, can't use pressure support in assist control, okay, and 50% oxygen. If the patient doesn't do anything on these settings, every 6 seconds, right, because there's 60 seconds in a minute, he's on a rate of 10, every 6 seconds the machine is going to give him a breath, and he's going to get 600 milliliters of tidal volume, like that. 6 seconds later, same thing, okay? Now, on assist control, suppose he wants another breath in 4 seconds. It's going to give it to him in 4 seconds, and it'll look just like the others did. The flow set, the tidal volume set. The only thing the patient has any control over if he's awake is when he wants another breath, the machine will give it. Because it's controlled mandatory ventilation or assist control, it will not, if he takes this breath after 4 seconds, when will his next breath be? Provided he doesn't want another breath. 6 seconds after that.
After that.
After that one. It's not 6 seconds
It
after
presets
this one.
itself after
Machine, it's a
that.
safety mechanism. So if he wants to, if he machine gives him a breath, let's make this quicker. My scale's too long, too small. 6 seconds apart. Say he wants one at 4 seconds, it'll look the same. The next one after that won't be for 6 more seconds. So the only work of breathing he's doing is what?
Spontaneous breath.
No, it's sensitivity when he triggers
Yeah,
the
when he
demand
triggers
valve.
that demand
That's why it's called assist control or controlled mandatory ventilation. The only work of breathing he's doing is the amount of negative pressure he has to generate to open the demand valve.
Open that valve.
Okay? And every breath will look exactly the same. Okay? So let's do it. See, machine breath, 600. Same thing. What's his pressure curve? Depends on the compliance of his lungs and his chest wall. Okay? So let's say they're going to all look the same on this. He's on a PEEP of 5, so he's going to start at 5, right? The machine gives him a breath, say it goes to 30. The machine gives him another breath. Let's do the 4-second one though. What's it going to look like? He's got to trigger the machine, so it's going to go down to 3, then it's going to look just like that. Okay? So that's how you can tell if the machine gave him a breath or he took a breath, because on the flow volume loop, he's got to open the demand valve. So initially, he's got to go below 5. Okay? So that's assist control. So in assist control, the only work of breathing the patient does is to generate enough negative inspiratory pressure to drop the sensitivity and open the demand valve. Fair enough?
Fair enough.
Let's do IMV with nothing else. Now we got an IMV of 10, tidal volume of 600, PEEP of 5, no pressure support, 50% oxygen. Okay? Machine gives him a breath. Machine gives him a breath. Patient takes a breath. okay? Maybe something like that. He may get more tidal volume. Because at this point, he's breathing completely on his own without any pressure support. What's our pressure do? Well, we start at 5. Let's just say it goes to 30. Goes to 30. What's his breath do? It's a negative pressure. That's how you and I breathe. So he's generating a negative pressure. So the pressure curve is actually inverted on IMV. Now, let's do IMV and pressure support. So on IMV alone, what work of breathing is the patient doing?
That would be that negative pressure.
Yeah, he's doing a fair amount usually. That's why we don't use it. Because every breath he takes unassisted that he triggers the machine, machine's not giving him anything.
He doesn't have any
He's
pressure
doing
to
it
push
himself.
it
Right.
open.
Now you add 25 of pressure support to that. She's a little bit longer. It's going to 600. It's going to 600. He takes a breath on pressure support. The volume, I mean, it's going to vary. It depends on his compliance. But what does our pressure curve do? Machine breath, his breath, what's it going to do? He's going to trigger the demand valve, so it's going to go down, and then it can't go above what?
25.
30. Peak of 5 and 25 of pressure support.
Yeah.
So it can't go above 30. Okay? So if you have enough pressure support set for him, again, the only work of breathing he's doing is triggering their demand valve. Okay? Now what do we use mostly around here?
Yes,
CPAP pressure support. Why do you think that is?
It's more comfortable.
Yeah, absolutely. I mean, that's why we don't have to use nearly the sedatives most people do. And that's why people come off the ventilator faster here than most people. Because it is the most comfortable way to be ventilated. So let's put someone on CPAP of 5, pressure support of 25, 50% oxygen. Okay? Machine, what peak flow you want him on? Doesn't matter because he sets it himself. He determines his rate because he's not on a set rate. He determines his tidal volume based on his needs, his lung and chest wall compliance, and he determines his peak flow, which is the same way we're ventilating. Instead of negative pressure, though, it's positive pressure. So it's the most comfortable way to be ventilated. So suppose he takes a breath, okay? It's going to go up here. The next one, maybe a little higher, right? What's his pressure do? Well, he's on a CPAP of 5, so every breath he triggers it to 3, and it can't go above 30, right? Same breath. Suppose it's 10 seconds later, the pressure looks the same. The volume may change, but the pressure never changes, okay? Do you know how pressure support's terminated? When the demand valve opens, it gives him that pressure, PEEP or CPAP, because there's no PEEP. CPAP plus pressure support, and it holds that pressure until his inspiratory flow rate decreases by 75%. So they call it the peak flow 100/25. So when his inspiratory flow rate, his demand decreases to 25% of what it initially was, then the pressure support is turned off. Okay? So if we had a longer thing, the volume may well change on CPAP pressure support, but the pressure won't. Okay? And that's why he determines his rate, his tidal volume, and his inspiratory flow, because it's the most comfortable way to be ventilated. Okay? So, what work of breathing is he doing on this?
He determines.
Huh?
He determines that by.
Well, it depends on how you have your pressure support. I mean, we like to think we give them enough to where they're pretty well rested. But really, the only way you could tell is one of two ways. You could drop a bicord tube, which we haven't done in years, or you can look at the flow volume loop. If the flow volume loop is blunted like this, something like this, then he's not getting enough pressure support. He's doing a fair amount of breathing. Whereas if it looks pretty physiologic like a normal flow volume loop will, then you're probably giving him enough. So he's doing the work of breathing to open the demand valve. Once it's open, there is no set volume, it's a set pressure. So the tidal volume depends on the compliance of the lungs and the chest wall and his inspiratory muscle strength. But again, it's the most comfortable way to be ventilated. So, I mean, you can tell how hard he's working. In a COPDer, pressure support 25-30 is usually plenty. A big fat person, it may need more than that. Now, pulmonary fibrosis is a different thing, but we want to talk a second about severe obstructive airway disease. So if you're trying to get a higher I to E ratio, so you're trying to deliver that pressure or tidal volume at a faster flow to give them more expiratory time, right? So we want to increase the I to E ratio. And these are our our knobs and buzzers we have. And again, most of the time this isn't that important, but in severe obstructive airway disease it can. So we want to try to minimize their auto peep, right? Their air trapping to where they have more time to get the air out. Well, what can you do with the rate? Slow it down, because the higher the rate, the less time they have in expiration. So you can hypoventilate them, right? So you can decrease your rate, and that will increase your expiratory time. What can you do on your tidal volume? You want to give them more time to get air out. So what takes longer to get out? A higher volume or a lower volume?
Lower volume.
To get more time to get out, it's a higher volume. So you want to decrease your tidal volume, right? To allow more expiratory time. What could you do to your peak flow? You want to deliver it faster to give them more expiratory time. So you want to increase your peak flow. Again, the trade-off for that is a higher peak inspiratory pressure because we're in IMV with a tidal volume at this point. What could you do for your waveform to give them more expiratory time? Square. That's right. It's delivered faster. Now, what about on pressure support? CPAP and pressure support. It's usually not that big a thing because usually if you take someone with bad air traffic and put them on CPAP and pressure support, because they can regulate it themselves, usually their auto peak will go down, okay? The other thing you can do in IMV or assist control if they have a high auto peak is you can actually increase the peak. And it'll help with auto peak, and I'll show you why. Actually, we'll do this curve. Pressure. Suppose you have someone in an IMV 10, tidal volume of 700, PEEP of 5, 50% oxygen. Okay? If they're air trapping and they have say they have 10 centimeters of auto PEEP, the machine can't tell that. Okay? So the machine's still reading this. Their pressure is going to be, something like this. Where in all honesty, if they have 10 auto PEEP, the actual pressure is up here. So to trigger the demand valve, they've got to go down from 15 to 3, which is a lot of work of breathing. Whereas if you tried everything else and they still are auto peeping, you can increase your PEEP to 12, where they're only going down 3. Okay? But that, again, you have to put a stethoscope on the patient, see how long it takes them, whether they're getting all the air out or not, and look at their flow volume loop and see if the expiratory loop is coming to 0 or not. And that's the only way you can really tell auto PEEP, although there are some things you can do on the ventilators we have now that will tell it. So that's basic mechanical ventilation, and it's really quite simple. So if you're in sys control, what work of breathing is the patient doing? Shake your head, tell
Just trigger.
Huh?
Just trigger that negative pressure.
Only
Just that
only
little valve.
opening the sensitivity
Yeah, that
valve, the
sensitivity
demand
valve.
valve, when he wants an extra breath.
Right.
If he doesn't want an extra breath, the machine's doing it all.
Doing it all.
Okay? On IMV with no pressure support, what work or breathing is the patient doing? On the delivered breath, none.
Right.
But when he takes a separate breath, he's doing all
Of it on his own.
Okay? On IMV with pressure support, and he wants an extra breath, what work or breathing is he doing? Opening
He's
the
gotta
demand
open
valve.
the demand
Okay?
valve.
And on CPAP and pressure support, where he's setting his own rate, flow, and tidal volume, what work or breathing he's doing, is he doing provided you have adequate pressure support?
So,
Just opening the demand valve.
yeah, he's doing.
So why do we not use IMV with no pressure support? Because it's significant work of breathing. The only people that use that is surgeons. Here you don't see it because the surgeons consult us, but in some places they do, and they wean by that. But it's easy. They weren't on a ventilator before surgery. They can come off a ventilator.
Right.
Let's talk about weaning. You have TP's trials, you have IMV wean where you turn the IMV down, you have pressure support wean where you progressively decrease the pressure, and you have spontaneous breathing trials. There's only one type that's ever been shown to shorten duration of mechanical ventilation. What is it? Hmm?
Spontaneous.
Yeah, spontaneous breathing trials. That's why we do them. There's no difference, according to the literature, in the reintubation rate whether you do it for 30 minutes or 60 minutes. There's actually no difference in the literature whether you get a blood gas or don't get a blood gas. Usually if we're leaving, we'll get a blood gas, but a lot of times you see us just stand there at the bedside and look at their tidal volume and their rate, and say just extubate them. But spontaneous breathing trials, interruption of sedation, the only thing that's ever been shown to decrease duration of mechanical ventilation. Oh, and physical therapy. Make sense?
Mm-hmm.
That's all I know about mechanical ventilation.
Tell us why you don't like assist control. I know like they have to do
Tell
a lot
us
of.
what?
You were gonna say why you didn't like assist, or why we don't use assist control.
Well,
Elaborate more. You already said a
it's
little
all
bit.
right if you have someone with a really high work of breathing, okay? Like you have a bad pulmonary fibrosis patient that has a very high mechanical ventilation. The problem with that is it's much easier to get air trapping on that. It's a higher incidence of barotrauma. And if you look at modes of mechanical ventilation, mostly animal data, where they do diaphragmatic biopsies, the incidence of atrophy of the diaphragm is higher on that mode than it is on any of the others.
Why is some physicians like that better than SIMV?
Why does what?
Like we have one here. He
Probably
always
removed.
uses
Yeah.
assist
That's where I was trained.
Okay.
Where I trained as a resident, we put everybody on assist control.
Mhm.
And as a fellow, we did. And your need for sedation goes up
Mhm.
markedly on that.
I know, because we're so
Painful.
much better on sedation than other, I guess because the comfort, like you said.
What else?
Are you finding that the spontaneous breathing trials that they're doing are assisting you in making your
Oh,
decisions
absolutely.
for respiratory? I mean, are you
Absolutely.
happy with what you're getting and whatnot? Are you really using them twice a day, or are you really just looking at the one in the morning?
I only look at when I'm here.
Right.
I mean, if they
that
call,
one in-
if they call me in the
Yeah.
afternoon, I'll
Or-
extubate people, absolutely.
You have, okay,
Yeah.
okay. All right.
What cases do you not do an SVT?
What?
What cases would you not do a spontaneous breathing trial?
Well, if they're on pressors, you have to be careful, although we have extubate on people on vasopressors all the time. If their minute ventilation is very high. I
And if your
think it's gonna
FiO2,
work.
right, is higher than a certain.
You gotta be able to deliver the amount of oxygen they need without a ventilator.
Right, and your amount of PEEP, is that right? Is that part of it?
There are some, according to the protocol, I think it ought to be 8 or less, but
Right,
we've certainly extubated people with more than that.
yeah, and then the Glasgow coma scale, of course.
Yeah, I mean, the argument can be made on those people to wean them and leave them on a T-piece, but you
Yeah,
probably won't extubate those people depending on the Glasgow coma scale.
okay, right. That's it.